proceed. So what is cancer screening, right? So this is when we try to look for cancers before someone has any symptoms of anything. When your primary care physician recommends for a cancer screening to be done, it doesn't mean that they think you have cancer at that point, right? It's just really to screen to look for cancer before anyone has symptoms. These tests are not meant to diagnose cancer, but the hope is to find cancer at an earlier stage, at a point where it's easier to treat and hopefully even cure. So when we talk about cancer screening, there's several steps, for us to do this. And a very important part of it is the history taking and the physical exam. So with the history taking, personal history of any cancers, family history of any cancers, and also environmental exposures will come into play. Some of these tests involve laboratory testing. Some of them involve imaging procedures and even genetic testing. There are risks involved when we screen for cancer. We can end up with a false positive result, meaning, you don't have cancer, but you have a test that comes back that's saying, oh, it's positive for something. That can be quite disconcerting, right? If we have that. So that's one of the risks. Next is you could have a false negative result. So this is a scenario where there is something concerning there, but the test didn't pick it up. Or we could have a scenario where, we found something, cancer early, but there's not much we can do to improve the patient's health or even help the person live longer. So these are some of the risks that we have to look into when we screen for cancer. And with these risks in mind, shared decision-making is very important when deciding whether or not to proceed with a screening test, right? The patient needs to understand the risks and benefits of a test, why we're doing it. Once you have that discussion with your patient, then you decide whether or not to proceed or not. And, whatever the patient's decision is, we then document that on the medical record. The goals for cancer screening are, as mentioned earlier, to find cancer before symptoms are apparent. And we don't just screen for any cancer, right? We want to screen for cancers that, if found earlier, it's easy to treat or cure. And, you want a cancer screening test that gives you very few false negative and false positive results, and hopefully decrease the chance of a patient dying from cancer. There are certain risk factors that come into play that would make us recommend these tests. In patients who have higher risk for certain cancers, we may need to screen at an earlier age, start screening early, and then screen more frequently, right? So some of these risk factors are personal history or family history of cancer, certain gene mutations, or exposure to certain causative agents such as tobacco, smoke, or certain chemicals at work. So let's start with breast cancer screening. So majority of women have less than 15% lifetime risk of developing breast cancer, right? So this is considered average risk. The age, for average risk women, age is the most important risk factor in the decision about when to start screening. As we get older, breast cancer incidence goes up. At the age of 40, this incidence is quite low, right, for an average risk woman. So for breast cancer screening, we start screening at the age of 40 up to 75 years old. Depending on which group you look into for recommendations, like, for example, the United States Preventative Task Force, we started at 40 years old at one point, and then a couple of years ago they said we'll start at 50, definitely for everyone, but individualize the decision making for patients 40 years or between 40 and 49. But currently they're reviewing that recommendation. So for the purposes of this talk, I put in 40 to 75 years old. For the Obstetrics and Gynecology Society, they do recommend starting at 40 years old still, and the cancer societies. So, we start at 40 years old up to 75 years old. In the interval, again, depending on which you're looking for recommendations, they recommend it to be every 1 to 2 years. So, if we're able to do it every year, I think that's a good thing to do. For women who have moderate risk. So these are women who have 15 to 20% lifetime risk of developing cancers. And this includes women who have a family history of breast cancer in a first-degree relative, but who do not have a known genetic syndrome. So for women with moderate risk, we recommend screening mammographies the same as for those with average risk, so starting at 40 to 75 years old and 1 to 2 year interval tests. So now for women with high risk, these are women with known genetic susceptibilities, or those with a history of chest radiation before the age of 30, having had certain breast conditions such as atypical hyperplasia. These women have a calculated breast cancer risk of greater than 20%. So in these cases, aside from mammography, we want to supplement with a screening MRI. A common approach is you do, the mammogram and the MRI every year, and sometimes they stagger it. 6 months, you do the mammogram, and then 6 months later, you do the MRI, and so on and so forth. And others would do them together, right? And for these high-risk individuals, genetic counseling would be important, and even referral to a high-risk clinic for consideration of any risk reduction treatment that may be beneficial to them. Okay, so next one, cervical cancer screening, another screening test that not a lot of women are too excited about doing, but equally as important. So cervical cancer screening, we start at the age of 21 all the way to 65 years old, right? For women ages 21 to 29, we do them every 3 years. If you do it just with a pap smear alone, that's when you take some cells of the cervix, put it under the microscope and examine those, right? Now for patients 30 to 65 years old, if you do a pap by itself, that's going to be every 3 years. But if you do a pap smear with co-testing, meaning testing for the human papillomavirus, which studies have shown to have a direct correlation, right? Increasing risk for cervical cancer. So if you do the pap with the HPV testing, you can do this test every 5 years. So for cervical cancer now, colorectal cancer screening. This test we do from 45 to 75 years old for average risk individuals. Now, for individuals who have an immediate family member who was diagnosed with cancer, you want to screen at 40 years old or 10 years from the age of that family member's diagnosis, whichever one is earlier, whichever one's younger. Most of these colorectal cancers, they arise from adenomatous colon polyps. And these polyps occur in about 30% of men and about 20% of women. A colon polyp, of course, must be biopsied to determine the kind of cells that it has. Certain pathologies have a higher risk for turning into cancer, while others are more benign. So the progression from a polyp, from an adenoma to cancer, takes approximately 10 years on average. And so that's why when you have a colon cancer, a colonoscopy that's normal, the screening interval is 10 years, right? So the benefits of doing colorectal cancer screening is we could improve disease prognosis, especially since, the conversion from of an adenoma to cancer takes about 10 years. Detecting, a polyp, removing it early, you actually essentially are preventing colorectal cancer, right? And then, of course, detecting it at an earlier stage makes it easier to treat and hopefully have a lower mortality rate for the patient. The risks, of course, in doing colorectal cancer screening mostly involves harm, involving colonoscopy. This would include perforation. Of course, you have to be put under anesthesia, so there's that component as well. To screen for colorectal cancer, there are several test options. I mean, earlier I mentioned mostly about colonoscopy, but there's other test options. So let's start with colonoscopy. So this is where, you see a gastroenterologist, they put you under anesthesia. They put a camera through the colon and they actually visualize the inside of the colon. The benefits of this is, when they're in there, if they see a polyp, which could be a precursor to cancer, they can remove it. You know, depending on how many there are and how the size and the pathology, then of course they would recommend, 10 years if everything was normal, 7 years on the repeat, 3 years, sometimes even repeat in 1 year, right? Of course, with this test, you would need to have someone drive you after anesthesia. We don't recommend that you drive, and there's some, prep work to be done before a colonoscopy. Now, another way to screen is you can do a stool test, or what we call the fecal immunochemical testing, very easily done at home. You look for traces of blood in the stool. Now, if this is negative, you can do this every year. Easy to done, no prep work, and you don't have to miss work. The big difference between, of course, the colonoscopy and the immunochemical testing is that, as far as sensitivity and specificity for colorectal cancer, they're both up there, although much higher for colon cancer, for colonoscopies at 95%, and when you do you're at the 73.8% when you do the FIT testing. But for the big difference really comes into play when you're trying to screen for adenomas. So much lower specificity and sensitivity for adenomas, those precursor for cancer lesions, when you do a FIT test versus a colonoscopy. The CT colonography, that's another option, but this is really viewed as a second line option or third line option, not for screening. So it's the same thing with the sigmoidoscopy, which is like a colonoscopy, but they don't go all the way through the entire colon. Now, for any of these other testing modalities, anything that is abnormal, that's not a colonoscopy, it needs to be followed by a colonoscopy, and ideally within 3 months, to make sure that we're not missing anything. All right, so next we have lung cancer screening. Lung cancer is the leading cause of cancer-related deaths in the United States. With that being said, smoking prevention and cessation will give you a much greater impact in reducing morbidity and mortality than screening it by itself, right? So, and I wanted to note that chest X-ray is not a recommended modality for lung cancer screening. So to do lung cancer screening, we order what we call low-dose computed tomography. It's like a CT scan for lung cancer screening, recommended for patients 50 to 80 years old who has a 20-pack year smoking history and currently smokes. So say you have a patient who smoked half a pack a day for 40 years. So that's a 20-pack year smoking history, right? So, or someone who smoked for 10 years, but they smoked 2 packs a day. So that's also a 20-pack year smoking history. And if they fall within that 50 to 80 year range, so then they would qualify for this. Patients who quit smoking within 15 years from this discussion, they would also qualify for a lung cancer screening. You do this test yearly, and you discontinue screening when the patient has not smoked for 15 years or more, or if they develop any condition that limits their life expectancy, so then we could stop screening at that point. So for ovarian cancer screening, the United States Preventative Task Force recommends against screening for ovarian cancer or even for endometrial cancer in asymptomatic women. So, of course, if we have symptoms, that's a different story. We're going to follow that, but just for routine screening, no symptoms, there's not really a screening that they recommend for ovarian cancer. Same thing for pancreatic cancer. For asymptomatic adults, there are no recommended screening guidelines for this. Skin cancer, the United States Preventative Task Force concludes that the current evidence is not sufficient to assess the balance of benefit and harms, of skin cancer screening if the patient is asymptomatic. Now, if you see lesions, it's another story, right? So then that one we do need to follow. But the United States Preventative Task Force do recommend that, we limit exposure to ultraviolet radiation for persons aged 6 months to 24 years, especially if you have a fair skin type, to reduce your risk of skin cancer. And, this is my last slide for the day. I know that the talk is about cancer screening, but I wanted to throw in a slide for cancer prevention. All right. Many cancers are preventable. And, basic lifestyle changes can have a very tremendous impact on the rates of cancer. So first off, we have avoiding tobacco. So smoking cessation, smoking prevention, it can affect really, rates of lung cancer, leukemias, oral cancers, paranasal cancers, pharyngeal cancer, laryngeal cancer, esophageal cancer, and you can see the list is quite long on the slide there: esophageal, pancreatic, liver, stomach, and even bladder cancers, right? So big thing that if we could avoid, we really should. Physical activity and being physically active is something that we would promote. Some studies are showing that this can actually help reduce colon and breast cancer incidence. Maintaining a healthy weight. So, weight loss for those who have a higher BMI, this can help reduce risk for colon, breast, endometrial, and pancreatic cancer. Having a healthy diet. So this is more of, diets that are not very high in processed foods, not too much artificial sugars. Such a diet can help reduce colorectal cancer and breast cancer also. And same thing with alcohol. If we could eliminate alcohol or at least limit it, this would reduce chances of oral, pharyngeal, laryngeal, breast, colorectal, and lung cancer. And then, of course, protecting against sexually transmitted infections, such as HPV or hepatitis. This can reduce risk for cervical cancer and liver cancer. And then for skin cancer, as mentioned before, avoiding sun exposure, too much ultraviolet light exposure, and, obtaining the appropriate screening, as we've discussed this past couple of minutes. So, that's it for my presentation today. If you have any questions, I'll be happy to answer them for you. Thank you for your attention.